Hello, everyone. I'm Christine Verini, the CEO of CancerCare, and I'm honored to welcome you to the launch of the Red Tape Report. For those of you new to CancerCare, we're a national not-for-profit that served the cancer community for over 80 years, providing free counseling, resource navigation, support groups, educational programs, advocacy, and direct financial assistance. Our oncology social workers improve the lives of people diagnosed with cancer, caregivers, survivors, and the bereaved by addressing the emotional, practical, and financial challenges. We're also national leaders in policy and research, working to ensure that everyone has access to timely, high-quality cancer care. As many of you know, prior authorization, coverage denials, and sudden care stoppages aren't just a paperwork problem. They can interfere with the treatment when people need it most. That's why we surveyed over 1,200 people with cancer nationally and created the Red Tape Report to expose how insurance red tapes delays care and creates serious burden for people with cancer. The report is a call to action for insurers, PBMs, policymakers, employers, and more. It reflects our deep commitment to breaking down care barriers and putting patients first. In today's session, we'll hear from Dr. Alexandra Zaletta, our Associate Vice President of Research and Insights at CancerCare, about the key results from the report. Next, we'll hear from Fumiko Chino, Assistant Professor of Radiation Oncology at MD Anderson Cancer Center. She will talk about the implications of these findings from a clinical perspective. And finally, Kim Zabarak, Associate Vice President of Policy at CancerCare, will discuss what this all means for policy and advocacy. Please feel free to drop in the Q&A box any questions. We'll get to as many as we can at the end of the session. Thank you for being here and for standing with us in this very important work.
Thank you so much, Christine, and welcome everyone to our release of the Red Tape Report. We're so thrilled to have so many of you joining us today for this important conversation and a call to action. And I'm really looking forward to diving in, sharing with you a little bit about this work, our results, and having our incredible speakers today talk about the implications of this work. So let's get right to it. We have a serious problem with red tape in insurance in this country. When we're talking about red tape, we're talking about utilization management strategies. And these strategies are at the outset intended to improve care and save costs. But the problem is that many of these policies lack transparency. They increase patient burden and they create access barriers that we have evidence to show delays diagnosis and treatment, increases patient costs, and even causes some patients to forego necessary care. And yet, this red tape continues to grow, and the evidence that it grows continues to mount. So we at CancerCare set out to do this study to really understand currently what are people facing, what are their experiences of utilization management in cancer, especially focusing on prior authorization, where people have to get insurance approval before they can begin a cancer treatment or a cancer procedure, as well as issues with coverage stoppages, folks having their existing care be disrupted because the insurer no longer pays for the care that they're receiving. And we wanted to not only understand the extent of these problems, but really, how is this affecting real people in their real lives? What does it mean for their timely access to care, their financial and their practical burdens, and their well-being? And so our goals of this work is not only to have this really important current snapshot of these real-world impacts in cancer, but to provide actionable insights to stakeholders and to make sure we have a benchmark so that we know what's happening now and we can continue to monitor the situation as the healthcare policy landscape and as these practices continue to evolve. So I'm going to cut to the chase. We have a lot of really critical findings in this report that I'm going to walk you through today. And I just want to tell you out front what we found. First and critically, prior authorization in cancer is widespread and it's highly repetitive. And this process and these inefficiencies are leading to serious time burdens and care delays for people with cancer. Also, some people with cancer are facing coverage stoppages that for many came to them as a surprise and it interrupted their care. And collectively, all these insurance problems are directly affecting their stress, their physical health, their finances, and their trust. In the face of all of this, while people are trying to navigate these systems, they continue to find barriers to their own self advocacy, including continued gaps in understanding their own health insurance and a lack of awareness of these, frankly, really complex and confusing systems factors behind the scenes that are driving some of these experiences. And also notably, we found differences in some of these findings based on the kind of insurance that people had, with those on employer-sponsored plans carrying the highest administrative burdens, followed by those in Medicare Advantage, and then those with traditional Medicare. So just to give you a quick snapshot of how we went about this work, again, this was a survey study. This report is based on real data, real voices. Anyone with a cancer diagnosis was eligible to participate. They also needed to be treated in the past 12 months with one or more different kinds of very active treatments so that we had a really, again, contemporary snapshot of people kind of going through therapy. We focus this work on those with employer plans and with Medicare Advantage plans because we came in because we've been hearing and having some concerns about there being increased red tape in these two kinds of insurance structures. We also collected responses from those on traditional Medicare as kind of a comparison group, because at least historically, folks on traditional Medicare should be subject to fewer insurance red tape strategies. And finally, we did limit this analysis and this survey to people who were age 26 or older because of the issues around the Affordable Care Act dependent coverage cut. We collected our data from September through December 2024, and we did this nationally. So this is a very current and contemporary snapshot that came in at the end of last year with people reflecting on their experiences in the year prior, very much their experiences during 2024. We screened over 47,000 people across the US. We didn't know if they had cancer. We were reaching out to them to see if they might be someone who could be eligible to take this survey. And we did that through using national survey panels. So these are folks that can become available to take part in research, market insights, people who are willing to learn about the opportunity to share their stories. From that over 47,000 folks, we found just under 6,000 people treated for cancer in the past year. And then we narrowed that down with further eligibility criteria to find just over 1,900 people who were eligible to start the survey itself. We very few number did not complete the survey, and then we did remove some other people after doing very careful data quality screening. So, for example, if someone obviously sped through the survey and didn't really answer the questions, they were removed before our analyses, and that led us to 1,201 complete and valid respondents. And so our survey was wide ranging in topics, really honing in again on prior auth experiences and time burden, coverage stoppages for people's ongoing treatment, care delays and denials, the impacts of these on their life, again, barriers to self-advocacy and awareness. And then we also collected people's self-reported information about things like their background, their treatment history, their clinical history. And I do want to just mention briefly that this was a project that was put through an IRB and determined to be minimal risk exempt research. I think one of the key differentiators and one of the really important things about this work is the approach that we take in driving person-centered research. So we never do this work alone, and we can't do this work alone in order to do this work well. We partnered closely with patient advocates and expert advisors across the country, coming from medical settings, advocacy settings, other settings, who were partners with us in developing the survey, vetting the questions, checking the language, and interpreting the data. And I know many of you are joining us today, and I just want to thank you so much for your time and effort on this. And they really held us accountable to make sure that we wrote a survey that made sense and used language that reflect how people talk about and understand their healthcare experiences in the real world. So we did not come at people with insurance jargon and say, did you have prior auth? We structured questions to ask them about their lived experience. Did you have to get insurance approval before you could start this treatment? Did the insurance stop covering this treatment? We said things like, you may have heard this called something like prior authorization, but we're not going to be using this language in the survey. And so I really feel that we landed on a final approach here that really resonated and made sense to help make sure we're getting the most valid, accurate information from these folks. Just to give you a snapshot of who was in this final survey, as I mentioned, we had over 1,200 folks representing 569 and employer plans, as well as those with Medicare Advantage and traditional Medicare. The results that we'll be presenting today and that are presented in the report very much are descriptive analyses, but we do also evaluate differences between insurance groups statistically. And for those of you like me who love to know all the details behind the research, please visit the full report for a detailed breakdown of all of our methodology and analytic strategies. So I'm going to give you a real quick rundown of a snapshot of who these participants were. We also have a comprehensive breakdown of this at the end of the report. But again, representing a broad range of different cancer diagnoses. These are just the top amongst a wide variety. People undergoing many different kinds of treatments, one or more in the past 12 months. About a quarter of the folks that took part in this survey had metastatic disease at the time of the survey. They were typically sort of the median 2 years from diagnosis, but that is not to say that there were not also many folks that were much closer or even newly diagnosed, as well as a handful of people that were further out from that. About half of these folks had ever undergone biomarker testing, 2/3 of them needing supportive medications for things like their pain and their nausea. They were treated in a variety of treatment settings, and many of them facing not only cancer, but other kinds of medical comorbidities, dealing with high blood pressure, pain conditions, psychological conditions, and others. We had, I think, a fair representation with respect to gender, age. About half of these folks were married at the time of the survey. About a third of them were retired, which kind of aligns with the focus and some of the emphasis on Medicare plans. We had really strong geographic representation across the entire country. And 39% of these folks had an annual household income of under $50,000. So also some meaningful, I think, financial diversity in our respondents. One call out that I do want to make as we do talk about differences based on the type of insurance that folks had is that those on employer plans, Medicare Advantage and traditional Medicare did differ in some statistically significant ways. So those with employer plans in our survey were more likely to have advanced disease. They were more likely to visit the ER for their cancer in the past 12 months. They more often reported poor or fair mental health. They were going through more treatments while going through all of this. They were younger, more racially and ethnically diverse, tended to have a higher education, and were more often working at the time of the survey. So let's dive in to these results so that we can really get the conversation started. The first takeaway point I really want everyone to understand is that prior authorization in cancer is and remains and continues to be widespread and highly repetitive. When we surveyed all of this over 1,200 folks, 85% of them told us that at some point in time, they've had to undergo prior auth before they could start their cancer treatment. So again, 85% facing this at least at one point in time in their cancer care. And this was really widespread across all of the different kinds of diagnostic procedures, surveillance procedures, interventional procedures, and even supportive medications. There really is no intervention here that's being spared from this process, with more than 2/3 to 3/4 of folks telling us, yes, if I was, I got the biomarker testing, but before I could, I had to undergo prior auth. I got the chemotherapy before I could, I had to undergo this, or I was trying to get it and I had to undergo prior auth before I could access it. The problem here is that in addition to all this sort of tremendous burden on the cancer side, half of the folks that are being prior auth for their cancer care are also undergoing prior authorization for prior auth for one or more other medical conditions. So they're really in this position of double or maybe even triple jeopardy here, where not only are they trying to manage the insurance red tape for their cancer, but they're facing it for their cardiac condition. They're facing it for their diabetes. They're facing it for their psychological care. They're facing it for their arthritis. And so for many people, this is really becoming kind of an additive or stacked experience as they try to navigate this red tape across all of their health conditions. When we take a look and we focus at the last 12 months, so people reflecting on their time right before the survey, we find that this is also a current problem for folks. About 3/4 of them had to face prior authorization in the last year alone. And this is where we start to see some of the disparities and the differences across insurance types. So those on employer plans, 87% of our respondents with employer plans telling us, yes, I had to get prior auth in the last year. And 43% of those saying, it happened to them for 5 or more types of their cancer care. So they're getting prior auth at the diagnostic imaging. They're getting prior auth potentially at the biomarker testing. They're getting prior auth when they're facing chemotherapy or radiation. They're potentially getting prior auth when they're trying to access their supportive care medications. This is a recurrent, pervasive thing that's happening at multiple points of the cancer care continuum. Those on Medicare Advantage also reporting prior auth at very high rates. 72% said they had to face it in the last year alone. 23% of those, nearly a quarter, saying they also had to undergo this for 5 or more types of cancer diagnostic and interventional therapies. And those on traditional Medicare, lower but not off the hook. 57% of those folks also saying they had to face prior auth in the past 12 months, sometimes multiple times. And again, when we break this out and look at it across these different kinds of interventions and therapies, we tend to see, again, there's not really any one kind that's spared from this process, but if you look at this pattern of results, this teal color, these teal bars, consistently the highest for folks on employer plans, again, followed by those on Medicare Advantage and then traditional Medicare as well. So in many cases, we've got half to 2/3 of folks saying that they are having to face this in order to be able to access their care. And we had some open-ended questions in the survey, and we asked people, and they were not very leading questions. We asked people just to be able to share what they wanted us to know, what they wanted some of the decision makers to know about this process. And they're telling us, it's a nightmare every day waking up wondering if some people halfway across the country are going to prove what my doctors have said is my only chance. And then saying, my doctors know what's best for me. That's their job. I don't believe a third party should be saying what I do or what I don't need. And so the problem with this collectively is that this prior auth is leading to real patient impacts. It's leading to tremendous time burden and it's leading to care delays. It's not just the red tape, but it's the impact of the red tape. So first, just out the gate, you're seeing almost everybody's kind of having to go through this process. That initial decision, 1 in 10 of the folks were initially denied. So a lot of people actually out the gate are getting that care approved, 1 in 10 of them being denied. The problem here is all the time costs sunk and all the effort that's going in, even just to get to that initial approval, where many people are facing shorter delays of just a day or a few days, but many people facing delays of a week or 2 weeks or even longer. And again, we find folks on employer plans reporting longer delays when it comes to just getting that initial prior authorization decision. And then for those that were denied, that didn't get that initial approval, who find themselves going through the appeals process, and many of them did, they now again have this stacked effect where not only did they have to wait for that initial decision, but they're now being put through potentially multiple appeals in order to be able to access that doctor prescribed care, where we have a quarter of folks saying they had to wait at least 2 weeks, 12% waiting 3 weeks, and over 30% saying they had to wait a month or more. And even some folks saying they waited as far out as 6 months or 7 to 12 months. Some of them were still fighting for that authorization at the time that they took the survey. And so we're sort of faced with this conundrum here, or this sort of contradiction, if you will, because in the end, 95, almost everybody's getting put through prior auths. 95% of them, after all the appeals and everything is said and done, they told us were eventually approved. But again, that only came after the expense of things like diagnostic delays, treatment delays, and time lost to fighting the red tape. So this is a really inefficient process, and potentially really overly broad process that all these folks are being subjected to, that are creating these impact and outcomes only for them to ultimately have that care approved. In our survey, 29% of folks told us, because of this prior authorization experience, my diagnosis was delayed. And those on employer plans, larger proportions of those folks were likely to tell us that compared to those on Medicare Advantage and traditional Medicare. And the length of these diagnostic delays also really mattered for folks, where we had, more than a third of these folks telling us, okay, well, it was 2 weeks or longer than 2 weeks. We had more than 1 in 5 telling us it was 3 to 4 weeks to more than a month that their diagnosis became delayed because of the prior authorization process. Unfortunately, we saw these impacts even greater on the treatment delay side of things, where 40% of everybody told us, yeah, my treatment was delayed due to prior authorization. And again, those rates essentially being almost twice as high for those in employer plans relative to those with the Medicare plans. And again, the length of these treatment delays for some folks being substantive, for some folks dragging on from 3 to 4 weeks or even more than a month. And the problem in this space is that this is creating burdens for multiple people that are trying to navigate the system. And so we all know the tremendous role that the healthcare team is playing in helping to navigate this, having peer-to-peers, doing all the work to help to really move this work forward as fast as possible. But what I think this survey also shed light on is the fact that people with cancer and their families are having to roll up sleeves and get involved in the process as well. More than about half of our respondents saying, I had to get involved in this process. And that involvement happening more frequently for those that were on employer plans, especially. And then about a third of folks with Medicare Advantage and traditional Medicare getting involved. And when they say they're getting involved, what that means is contacting the insurance, contacting the pharmacy, getting involved in appeals, doing personal research, managing other kinds of tasks. And the pain point here is that this is becoming time sink for many people who are losing multiple days of their lives to fighting this red tape. So amongst those who did roll up sleeves, half of them lost what we're calling a business day, 8 hours of their lives, to fighting just a single incident of prior authorization. More than a quarter of them lost up to 2 to 3 business days. And then 1 in 10 lost a full business week or more, again, to fighting a single incident of prior authorization. And I'll remind you that many of these folks are undergoing this 2, 3, 4, 5 times in the last year alone. So this, again, really puts people, I think, in this difficult position of having to navigate this and lose significant amount of time to what number one should be focused on is their recovery and their healing from cancer. Number two, their family and their loved ones. And number three, their other priorities, whether that includes being at work and being present and focused at work, engaging in things that matter to them that are instead being put towards this really inefficient process. And again, our respondents were really clear with us in saying, I want you to know the wait was very long and it was scary. I had to deal back and forth with the insurance company. Every time you call them, they don't care. It takes forever to talk to a real person. And so in addition to this really extensive level of prior authorization, people with cancer are also facing coverage stoppages that at times surprise them and can interrupt the ongoing care that they're receiving. Again, when we asked all of our survey respondents, all 1,201, whether or not they've ever had their insurance stop covering an existing treatment, nearly 1 in 5 said, yes, this has happened to me at some point in my cancer care. And I want to be really clear what we're talking about here. These are people that are on their existing insurance, and their existing insurance is saying we're no longer covering the treatment that you're getting. This is not the situation where someone has changed insurance, changed plans, changed employers, and lost coverage or had a coverage transition. That's a really important separate conversation. But this is really focusing on folks who had their existing insurance say that they're no longer going to be covering the treatment that they're receiving. And it's a current problem as well. More than 1 in 10 saying this happened to them in the last year alone and before taking this survey in the last 12 months. And again, when we break this out and looking across the different types of insurance plans, 21% of those with employer plans saying, yeah, this happened to me at least one time in the last year, compared to 9% with Medicare Advantage and 8% with traditional Medicare. So while the rates are smaller than prior auth, we still are seeing people that are, they really are being affected by this. And we can see disparities in this across the different plans. And again, for many folks, they were caught off guard by this. Half of them did not know in advance that this coverage might stop and that they had to face this. When they did know, it was generally because the healthcare team tipped them off that that was a possibility. And unfortunately, for those facing the circumstance, many of them, perhaps unsurprisingly, but very distressingly, had their treatment interrupted because of this stoppage in coverage. About 2/3 of everybody saying that. And again, those rates being higher amongst those with the employer plan who had this coverage stoppage relative to those with the Medicare plans. And again, the lengths of these stoppages for some folks really substantial, more than a quarter saying, yeah, it was between 3 to 4 weeks to even more than a month that their treatment was interrupted because of this change in coverage from their existing insurer. And for several people, this translated to having to switch their treatment. And this is, again, kind of the contradiction that we face here because we talk about utilization management strategies as meaning to improve the care process, improve care efficiency, improve costs for people. But that's not what many of these survey respondents told us. Amongst those that had to switch treatment because their insurance stopped covering, 45% of them said, well, my side effects were worse on the new treatment compared to the original treatment, as opposed to only 19% saying the side effects were better. And 38% said that it cost them more after being shifted to this other treatment, whereas only 14% said, well, okay, it actually cost me less after this interruption and potential stoppage. And again, our respondents are telling us that stopping someone in the middle of treatment is wrong. And again, they're reiterating, when it happened, I had worse side effects than my original medication. And again, I also, for some reason, had to pay more out of pocket for the new treatment. So collectively, all of these barriers, problems, and pain points, and all of this red tape is really having significant impact on well-being and finances for many people living with cancer. When we look at everyone collectively across the entire survey, many of them are telling us, look, my stress got worse as a direct result of the problems that I was having with my insurance. They're telling us that their finances got worse, that they paid more than they expected for their care, that their physical health got worse, that they had those worse symptoms or side effects. And a number of people telling us, my trust in the healthcare system got worse. And even 1 in 10 saying my relationship with my doctor got worse because of these problems with insurance red tape. And when again, we break this out and we try to look at this across the different insurance types, consistently we see these rates highest on those with employer plans, 49% saying my stress got worse, 45% saying my finances got worse, and 40% of those saying my trust in the health system got worse as a direct result of problems with my health insurance. When we break down some of this from a cost perspective, and I know this is a lot of colors, if you haven't noticed, I love a lot of colors in my data, but I'll draw your attention to the right side of this graph where you'll see those on the employer plan are more often reporting higher annual out-of-pocket costs for their medical care. So looking in that dark green color, the 2,500 to 5,000, the purple, the 5,000 to 10,000, and the yellow, the 10,000 or more. Folks on employer plans more often reporting these higher amounts of out-of-pocket costs, followed then by those on Medicare Advantage and those, again, on traditional Medicare. And as a result, folks continue to make trade-offs to offset the cost of their medications. And we sometimes refer to this as medication scrimping, where we're having, significant numbers of people telling us, well, I'm taking smaller than prescribed doses of drugs, I'm postponing or not filling prescriptions, I'm skipping doses of prescribed drugs. Some people telling us I'm ordering meds online from non-US sources, and even people saying I'm taking someone else's medication in order to offset the costs of my medications related to my cancer treatment. And so for many people, this is really impacting their sense of confidence and satisfaction with their insurance. Those, especially on employer plans, more likely to report that they're dissatisfied with the out-of-pocket costs for their care. A number of folks not wanting to recommend their health insurance to someone with cancer, and a number of people wanting to switch their insurance due to problems with it covering their cancer care. And again, people reiterating to us that they become mistrusting of everything and everybody. All I get is the runaround. So angry with this insurance. I feel my cancer spread more because it took 6 months to get my referrals approved. I take it day by day. I hope I'll be a survivor. I'm not ready to leave my family. And my savings got wiped out. Now that I'm 66 and want to retire, I can't. I have nothing left to live on. I have to go back to work, and no one wants to hire an old lady. So many people are hurting, and they're really working very hard to try to navigate forward. And I think one of these pain points is that there continue to be knowledge gaps and system awareness gaps that make it difficult to navigate the system. Now, I hate to put that burden on the shoulders of people with cancer. In a sense, it shouldn't have to be on them to navigate the system. But that's our current reality today, is that having awareness and having the empowerment to get through this process is an important part of making sure that people can get access to the care that they need. Because despite all of our work and efforts in this space, about 1 in 4 of our respondents are still telling us, you know what, I don't understand, and I don't know how to figure out the coverage or the costs for my healthcare visits or services, and I don't know how to figure it out for the prescription drugs that I'm getting either. And they're not aware of these complex structures or don't understand how they work. So we asked them about whether they knew what a PBM was or had heard of them or understood how they worked. And more than 3/4 of our respondents saying, I've never heard of them, or I don't know what they do. This is the one place where we see actually kind of a reverse effect by insurance type, where those in employer plans, a little bit more likely, still 72% really not knowing how this works compared to those on traditional Medicare who may be less likely to encounter some of these PBMs. 89% of those folks on traditional Medicare not having that awareness or familiarity. We also spoke to those specifically on employer plans to ask them a little bit more information about their knowledge and awareness of things like whether or not the plan is fully funded versus self-funded. And again, folks, many of them not having awareness of these structures. And it may not be a surprise, but this is also a barrier and a pain point because these kinds of plan structures matter for the amount of flexibility that an employer has and the kind of benefit design they might be able to bring to the table. It has implications for what the appeals process can look like for people. So again, not having this awareness makes it challenging to know how to navigate the system or even advocate to your employer about possible changes. And so really, again, in the end, people are just emphasizing us. It's too much red tape to go through. It's always something that has to get done and we're not able to get it done. Some people just need help paying for their treatments without going through a whole bunch of mess. So our results collectively, I think, really underscore the fact that people with cancer, again, are facing repeated prior authorization cycles that are leading to care delays. They're facing this excessive red tape that drain their time, increase their stress, obstruct their care. We are in a position right now where we have to be reforming these and other cost containment strategies to protect timely access, high quality and affordable cancer care. And so this is our call to action. We need these system-wide changes to reduce burden so that we can support and not hinder treatment. And it's the time for coordinated action, not excuses, from insurers, PBMs, employers, policymakers, providers, and all of us as advocates, along with better tools to help people with cancer navigate their insurance and shape the policies that affect their care. And so just very briefly, as I wrap up my portion, I need to acknowledge, number one, our incredible project advisors and patient advocates who have worked so hard to support every step of the way along this project. I'm so grateful to all of you for your insights, support, and expertise over the past many months of this work. I must acknowledge our funders. We are not able to do this work without support, and it is so important to bring these patient voices forward. And finally, to my incredible report team, Adam Tominelli of Praxis Research Partners, Julie Olson, Whiting Communications for the incredible writing support, and to Hello Brand for the gorgeous graphic design that I hope you're all appreciating today. And so with that, I'm going to throw it over to Dr. Fumiko Chino, who's going to bring her great wisdom and expertise and talking about the implications of these results from the provider perspective.
Thank you so much for that summary of the findings. I will say that as a practicing radiation oncologist, they certainly align with my experiences. Just so you kind of know who I am, I treat people with cancer at MD Anderson Cancer Center in Houston, Texas. I also do research on things like prior authorization that can create essentially access gaps and affordability gaps for patients. So I'm very passionate about this topic. Next slide. So I'm going to show some of the slides that we've already presented, just as a framework for me, for my discussion from the provider perspective. Certainly what was presented aligns with my experience that it's a really broad scoping problem that really affects every part of the care cascade from diagnosis to survivorship. So there's really very little people who are not affected by prior authorization and these delays and denials. I'll point out that even the sort of best case scenario, for example, supportive care medications only needing about 60% of PA, still presents a huge barrier for the patients that I see in my clinic. Because when you think about those supportive care medications, there are people who are actively having pain, who are actively having nausea, And delays for PA on something like ondansetron or Zofran means that potentially someone is, then losing weight because they can't eat, or they may be hospitalized. It ends up being more expensive for the healthcare system, but it also has a huge emotional, physical, and familial burden for that patient and for that household. What the report shows is that there's quite a variation based on the type of insurance that people have. We have now, unfortunately, in the United States, we're living in a kind of world of haves and have-nots in terms of who has quote unquote good insurance. Although, again, there's some sort of broad concepts that generally you're going to see more prior authorization barriers for private plans, which again certainly aligns with my experience. I want to point out a little bit from the provider perspective also that there's a significant amount of regional variation. So for example, I'm treating in Houston, Texas, but a year ago I was treating in New York City in a different healthcare system. And the burdens actually just from the state that you live in was quite variable. I think the specific insurance plans are quite different. And then the networks are also quite challenging. I will also say that, I've been privileged to work at a world-leading cancer center, and that means that I do see people with potentially a different insurance profile than was captured in the survey. So for example, in both of the centers that I've worked at recently, again, the #1 and the #2 cancer center in the world, there is very few Medicare Advantage plans that would contract with our cancer center. And that means that those patients couldn't even make it in the door. Next slide. From a provider perspective as well, what this shows is that there's this huge burden on patients, that patients are really wasting their time, trying to kind of go through these difficult phone trees, trying to actually get to a person who will be able to answer their questions or can actually make a difference. This is mirrored on the provider side as well. And so, for example, as someone who routinely goes through multiple PAs a week, for my patients on treatment, I just want to reiterate the fact that this time wasted is happening on the provider side as well. And it's actually tying up multiple staff members from our team. We have a whole prior authorization team at this point. And even that actually, I think, can show that there are large differences between, for example, a well-resourced cancer center versus a smaller cancer center, for example, in a rural area. The example I'll give is that, again, I work at MD Anderson. We have a huge team that's working constantly on prior authorization, and they're able to relieve some of those friction points so that it goes through smoother. Whereas, for example, my mom was practicing in Indiana as a physician. She's also a radiation oncologist. And in her practice, the person doing prior authorization was my aunt. And so you can imagine how those burdens are going to be uniquely felt within certain populations, the ones who, for example, aren't able to make it into the door to MD Anderson. And, for people who want to stay in the community, these burdens are really felt distinctly worse for those patient populations because of just the lack of resources. Next slide. I wanted to highlight a little bit about this kind of time burden in terms of like what happens when people are delayed for their cancer treatment start. In terms of radiation, what we know is that, every single day or week of delay up to a month of radiation delay actually has a meaningful and measurable, actually negative outcome for patients in terms of, for example, their symptom control or their disease control. So most famously in certain disease types that are fast growing, like cervical cancer and head and neck cancer, you can measure a discrete outcome, meaning that if you delay by 1 week, you have a 1% worse overall control in that area. And for cervical cancer is actually the absolute worst. It's 1 day to 1%. So that means something like a 10-day delay is going to have a worse control of 10% in the pelvis for that cervical cancer. So really measurable negative implications from these numbers that you see that are quite stark. Next slide. And then the last thing I'll highlight is that this is something that I see in my clinic routinely, which is that patients get this denial letter, they're terrified. Interestingly enough, often by the time they get the denial letter, the appeal has already gone through, their treatment is already approved. And so they have had this time where they have been scared. Maybe they've been calling their insurance. I've tried to reassure them. already, but sometimes, people want to be engaged, but it's already been overturned. It's already been approved. My team on the back end has been making duplicate plans to try to show, this is the exact benefit of this more enhanced cancer treatment, so that it can be approved. And so this kind of spiral that some of our patients go through is really often unnecessary. The vast majority of the PAs are overturned on appeal. And so this kind of emotional hardship is just really unnecessary. It also places actually additional burden on the clinic staff. So for example, the back and forth with the portal messages, with the phone calls and the reassurance, 100% that we need to provide that information, but it's additional burdens in addition to what we're doing on the back end for the insurance that sort of gums up the system. That's time that really we should be, directly addressing patient symptoms or facilitating their capacity for receiving treatment, and really not in this insurance red tape. So that's where I'll end it for my provider perspective. I'm really excited for the findings of this report. I think they're very helpful, and I'm excited to hear about what the next steps are in terms of sort of policy implications.
Good afternoon. I'm Kim Zabarik, Associate Vice President of Policy with CancerCare. And I'd like to thank Dr. Chino for her very helpful comments and from that provider perspective. Because as we know, stakeholders, there are a number of stakeholders, whether they be patients, providers, plans, PBMs, manufacturers, employers. It will take all of us to move the needle and make very significant and much necessary change. Before I start out on each of these bullet points or topics, I want to share, and I believe Alexandra mentioned this, but keeping in mind as we talk about these next items, that from the very beginning of creating the survey and doing this project, Alexandra and the entire team made it very clear that we did not want to do this tremendous work, have these very important, meaningful results, and then have those results sit on a shelf. So where are we now? What action can we take? Because it is time. It's time now. It's been time before, but we're here and we have the data, we have the stories, and together we know when you have data and stories, that's when real impact can be made. So I'll just start with the real challenge, I think, the base of many of these challenges is the complexity of our healthcare system in general. We have so many different forms of insurance. There's private insurance, there's individual, there's fully funded employer insurance, there's self-funded employer insurance, there is Medicaid, there's traditional Medicare, there's Medicare Advantage. So right from the start, we can see why so many of these issues, and each one has, different regulations, different laws that apply. So we can fully understand why patients are caught up in this. And often seemingly this red tape actually turns into what appears to be a very large and solid red brick wall for patients. We believe at CancerCare that if we keep the patient as the North Star, that all of the different stakeholders will indeed benefit, whether that be employers, whether that be the plans, whether that be the PBMs, I dare say. Obviously, also patients and all the other stakeholders and manufacturers, keeping patients at the center. It's a term we often say in policy. People mean it when they say it. They want everything to be patient-centered. But if we're going to be honest, our health system is not patient-centered. In fact, I dare say that patients are 2, 3, or 4 down on the list, unfortunately, because of the complexity of our system, even when the intent is to keep them at the center. So we need to do a better job at that. So what are some of the things that are existing that are put in place now and are taking place to help patients navigate this red tape and obtain the timely, appropriate care that they need? And what are some of the areas that are proposed for the future? So first and foremost, I would say that starting this year, the out-of-pocket cap of $2,000 for the Part D plans for beneficiaries is a huge benefit to everybody. If we think about it, almost every other form of insurance or plan had an out-of-pocket maximum on that, except really for some of our most vulnerable. Our most vulnerable on very fixed incomes did not have an out-of-pocket cap. So that was an absurd position to put our patients in. So when the $2,000 out-of-pocket maximum went into place, it got rid of the very cumbersome donut hole, the initial phase of coverage, the catastrophic phase of coverage, and all of that. So that is a huge, huge help. Second, which many people are not yet aware of in the patient world, is the Medicare prescription payment plan. And that is another type of reform that went into effect. And that is to allow patients the ability to spread out the cost of their medications. It was often found that when a medication hit a certain price, patients would abandon it at the pharmacy counter. It wasn't helping people's health. Adherence was challenging, and necessarily then outcomes could in fact be impacted. So those two things are in place, and those are very, very helpful. The 6 protected classes is something, for those of you not familiar with it, several years ago for Part D plans, a law was put into place that for 6 types of drug classes, those that address very serious conditions, that plans had to cover all or substantially all of those drugs. Anti-neoplastics or cancer drugs are indeed some of those, they are part of that 6 protected classes. So this is again for the Part D space. Very, very important. Now, that is not to say, and this is why this report and other reforms that we do for prior auth and step therapy, even within the 6 protected classes, those classes were still subject to prior authorization and step therapy. So as we improve the red tape burden, lessen it so that patients can receive their care in a more efficient manner, then everybody will benefit. And that really takes me to a point here I had above that, and more effective cancer care and all treatment for all diseases. The more effective care and timely treatment, the more efficient the system. And a more efficient system is indeed dependent on people receiving timely, appropriate care. Now, what are some of the proposed legislation or policy actions not yet in place, but that we're looking to indeed lessen this burden? A couple of them refer currently to the prior authorization issue. There is another on the step therapy issue. So one proposal out there that's been reintroduced is reducing medically unnecessary delay in care act of 2025. The AMA has spoken largely on this, and they're very supportive in addition to many other groups. And what this act would do, if passed, it would require that prior authorization decisions are indeed based on medical necessity. Secondly, and very important, and something that we hear a lot from providers and which causes real delays and problems for patients, is that when prior authorization takes place, this act would require that the person reviewing the prior authorization request actually be an expert in that field. So those are 2 very key things: medical necessity, and that the person reviewing from the plan is in fact an expert in that field. Another proposed piece of legislation, also regarding prior authorization, is improving seniors' timely access to Care Act. This would try to improve the timing through electronic prior authorization. It would try to improve the transparency of prior authorization. It would also look to Health and Human Services having more or defining what their authority is as far as defining timeframes in which prior authorization must be completed. Again, that would be another very helpful piece of legislation. With step therapy, which is where a patient is required to try less expensive drugs prior to having access to the drug that was prescribed by their provider, there's also legislation on that. We've come close several times. It is called the Safe Step Act, and that would really make exceptions on step therapy so that people would not have to try a different medication that was not prescribed by their doctor, and instead they can move directly to the prescription that they were provided, which they're provider believes is the most effective, appropriate medication for them. And the Safe Step Act really would do such things as the exceptions would be if you're already stable on a medication, you would be exempted from step therapy. If a medication could cause harm to a patient based on their history, you were exempted from step therapy. Things like that, which are very, very practical and very important and really address many of the issues that have been discussed here today. Another piece of legislation is the Help Copays Act. I won't get into too much detail. There is more reference to this in the full report. But when patients get assistance in order to help them be able to afford their medication, they get this assistance, and the health plan will accept that assistance, say thank you very much, but that assistance is not applied towards the patient's deductible or out-of-pocket cap. So that is proposed legislation on the federal level. Here's the kicker here, though. Many states have indeed implemented legislation both on prior authorization, as well as step therapy, as well as copay accumulators. But if we go back to my initial statement, our healthcare system is challenging. There's different laws that apply. So the state legislation only applies to state-regulated plans. So 31 states, about 31 states have enacted legislation on step therapy, reducing when a patient would be subject to that. That's great, but it doesn't apply to federal. In addition, about 23 states have enacted prior authorization laws. Again, wonderful, but doesn't apply to all. And about 21 states have implemented copay accumulator bans. Again, only limited to state. The employer coverage I will touch on because that is, for some people, was a surprise that it came out as perhaps the most challenging, or based on what our patients shared, it was the most challenging. Not that Medicare Advantage or traditional Medicare do not have significant barriers. And historically, employer insurance really has been the gold standard. It provided employees with tremendous access to very timely care. And like other stakeholders, employers have been caught up in the red tape, and they've seen necessary on behalf of their business to try to make decisions based on cost for the coverage that they can provide their employees. So while employees are certainly very grateful to employers to have coverage, the gold standard is somewhat tarnished because employees are paying significant money for their plan, yet the access is not what it used to be, and the burden is great, as the data in this survey illustrates. So we'd like to improve that. We'd like to work with employers, keeping in mind that when patients don't get the medication in a timely manner, the most appropriate medication in a timely manner, the most costly part of healthcare for an employer is actually hospitalizations. And when employees' health fails, hospitalizations rise. So we'd like to work with employers and figure out ways to make sure that their employees are receiving the most appropriate, timely care possible. And again, the insurance literacy barriers, which Alexander discussed, again, pose a huge hurdle. If you don't know if you have a fully funded or self-funded plan, if you don't know if you have Medicare Advantage or traditional Medicare, these are real obstacles and prevent you from advocating on your own behalf. Next slide, please. So again, I mentioned the stakeholders here. It is time to bring together all the stakeholders that can and must play a role in making these changes. Patients, caregivers, families, employers, insurers, PBMs. You see the list here. It goes on. It's probably many more than we've even listed here. But if we all come together and recognize keeping the patients as the gold star, that will lead to a more effective healthcare system, which is a more efficient healthcare system. Just wanted to share the next minute or so some upcoming CancerCare policy initiatives that we have to try to address these issues of red tape, barriers to care, and other burdens that patients place. So the Alternative Funding Task Force, some of you may be aware, alternative funding programs, it's another cost-saving measure used by some employers. The employers are told that this will save your company money and your employees will be fine. Unfortunately, that's not often the way it turns out. Again, more information is included in the full report, but we're leading a task force of about 26 different groups, cancer groups, as well as other groups needing specialty medication. And if you'd like to learn more, please reach out to me. We'd love to have you join us. We also have a new initiative that we'll be launching called Micro Insights, Macro Impact. And essentially what this does, it will be taking all this valuable information captured in this survey, and we'll be empowering patients, helping them understand the complexities of our system and empowering them to become advocates, but assisting them, helping them draft template letters that they can share on issues of importance to them to help improve their timely access. We will have focus groups. We will come up with a toolkit. And most importantly, for those who want to even go above sharing letters, we'll be inviting and empowering patients to join us on the Hill or with their state legislators to help address all of these barriers that we've been talking about today. 340B drug pricing program. Just speak very quickly that we are advocate of the 340B program when it is implemented as it was intended. And one of the very important intentions of 340B program is that savings can be used by facilities to increase outreach of comprehensive care to underserved patients. And when that happens, again, when those patients are kept at the center, then everybody benefits. And then finally, we have an initiative on the Medicare prescription payment plan. As I mentioned earlier, this is something also part of the Part D reform. Not many people know about it. There has not been much uptake about it. So it's very important if people need to know, would this help me? They don't know that if they don't even know the option exists. So we're going to launch a program that explains what the Medicare prescription payment plan is, provide considerations. Maybe, would this help you? What are your situations? We're not going to tell people. That's up to people to decide whether or not it will benefit them. But we certainly want them to be aware that there's an opportunity for you to spread out the cost of your medications over time so that you can adhere to your treatment as prescribed by your provider. So I appreciate the time today. And if you have any questions on any of the above, we'd love to hear from you. And my email is listed there. Well, I will turn it back over to Alexandra.
Thank you so much, Fumiko and Kim, for your incredible perspectives, the call to action. And I think if there's anything I want to double down here on in the messaging, it's our commitment to create change. We know that the time to talk is ending and the time for action is here. We want to be able to partner with you. I'm actually going to be moving forward a slide because I want to make sure that folks have the different ways to be in touch with us. I am seeing some very specific research questions that are coming in that I would love to address with some of these folks offline individually. But what I really want to emphasize for those of you that are asking, how can I take part? How can I engage? How do I have my policymakers hear my voices? Please reach out to us, join our e-newsletter because we are sharing advocacy opportunities. Kim was just speaking about the different kinds of programs and opportunities that are going to be coming our way. We also have a patient insights program for people that can be part of, share their voices, get involved in our work as we continue to grow out the advocacy work that we're doing in this space. So we want to hear from you. I'm also seeing some specific questions about people that are facing red tape, that are facing questions about care access, and actually that are facing questions around clinical trial decisions and what that means and how that relies to their insurance. And so I really encourage you to reach out to us. Please give us a call at our HOPE line here at 800-813-HOPE because we have our oncology social workers that can have that conversation with you, navigate you to the resources that we have and help support you so that you can make empowered decisions with your providers about what the right care choices are for you. So I thank everybody for your time, your investment. I want to reiterate to everybody that the full report is available at www.cancercare.org/red-tape. There is also an executive summary and a 2-pager of the most important highlights. And so please take them, share them, help us spread the word. This is the first step in this partnership with you all, not the last step. We really look forward to continuing to work together to cut this red tape. And so again, I'm just grateful for everyone's time. Thank you to the incredible speakers and thank you for joining us today.